Hi, folks. Welcome to the Silicon Valley Health Institute. We're a nonprofit organization where we aim to bring you top grade experts to give you information to help you on your path to wellness. My name is Susan Downs, and my co-host here is Stephen Fox, who's an absolute genius. And today we have Dale Bredesen, who's done some groundbreaking work on how to reverse the cognitive decline in Alzheimer's disease. He's internationally recognized as an expert in the mechanisms of neurodegenerative diseases such as Alzheimer's disease. He graduated from Caltech and then earned his MD from the Duke University Medical Center in Durham, North Carolina. He served as a chief resident in neurology at the University of California, San Francisco, before joining the Nobel laureate Stanley Prusiner Laboratory at UCSF as an NIH Postdoctoral Fellow. He held faculty positions at UCSF, UCLA, and the University of California, San Diego. He founded the Buck Institute in 1988 and served as its founding president and CEO. He's numerous television appearances. He's developing successful protocols to reverse Alzheimer's disease and an in-depth series on deuterium, as well as a startling series on the birefringent quantum properties of the major redox balancer, vitamin C. The ongoing series on COVID-19 is recognized around the world for its in-depth coverage of the disease and discussion on holistic alternatives for prevention and treatment. So he's going to tell us about reversing cognitive symptoms and any other questions you might want to ask him. So welcome, Dr. Bredesen.
Thanks very much, Susan. Thanks, Steve. Thanks for everybody for having me here. I appreciate it. This is my second time before the group, so I will try to skim over some of the stuff that I said the first time and focus on newer things and what things are up to. Our goal throughout the career has been to develop and understand the neurodegenerative process so that we can develop the first effective treatments. I think, as everybody's aware, the area of greatest biomedical therapeutic failure has been neurodegeneration. If you have Alzheimer's, or if you have ALS or frontotemporal dementia, Lewy body disease, just go right down the list. This has been a death sentence for so many years. And so our goal has been to do research to understand the fundamental nature of the neurodegenerative process, so that we can then develop the first effective treatments. And the idea here is, what's the best we can do for the patients? And I thought in that line, there was a wonderful article this morning about Eric Yuan, the founder of Zoom, who said he wants to make people happy. He wants to get the best outcomes and make it something that we can all use. And so, yeah, we want to make people healthy, as I know you do at Silicon Valley Health Institute. So this is something I saw when I was flying over to London, actually, and just showing that here's the guy, one of the very first Concorde pilots, and he had committed suicide. And why had he committed suicide? Well, because he had just murdered his wife. And why had he taken her life? Because she had Alzheimer's disease, and he knew that there was nothing that could be done. And this is the sort of thing, obviously, we want to avoid completely. This is really unfortunate. But as everybody knows, this is a story about much more than Alzheimer's. And as everyone who's been involved with functional medicine knows, this is truly a revolution. This is a changing the way we think about patients, changing the way we evaluate patients, changing the way we treat patients, changing the way we think about wellness. This is a huge issue. And great example of this just came up a week ago. Sure, everybody heard about aducanumab. So aducanumab is an antibody that binds to and reduces the amount of amyloid in the brain. And the theory was that amyloid is the bad actor in Alzheimer's. So if we can get rid of it, then you're going to do better. And so people have put billions of dollars into this. There's been bapineuzumab, there's been gantenerumab, solanezumab, crenezumab, and now aducanumab. No one's ever shown that this improves people. The best is, the hope is that instead of declining rapidly, you decline a little more slowly. And as one of the husbands of one of the patients said to me, when you have a spouse that is in late stage of Alzheimer's, the last thing you want is to make them decline more slowly. So this is really unfortunate. Now, what happened with aducanumab, as you may have heard or may have read, is that in one trial, it failed completely. There was no effect, no significant effect. In the other trial, at one dose, there did seem to be an effect, and another dose, there did not seem to be an effect. So the evaluators said there's no statistical effect overall. The FDA rejected it a while ago, and as many others, it would have gone away. But an internal statistician at Biogen reanalyzed the data and said, no, it seems like at that one dose, it does seem to have had an effect. And so Biogen actually asked the FDA to reconsider. So the FDA then reconsidered, and interestingly, before they had the meeting of the external impartial experts, they sent a smoke signal out saying, it looks like there's enough data to approve it. Things look good. So the company value went up by $20 billion in one day with that smoke signal. 2 days later, not even enough time for the champagne to lose its fizz, the impartial experts met and sharply criticized the FDA for putting out that smoke signal and said that they strongly recommended against approval. And as you can imagine, the stock went right back down, went down over $19 billion in that one day. So, these are huge, huge changes. And of course, when this much is at stake, and when there is a $1 trillion global problem that we call Alzheimer's disease, then it's going to get difficult for people to be completely objective. So we are facing a lot of different political issues, a lot of different issues with the way that medicine is practiced, establishment issues, as everyone knows. And this really is a huge issue. How are we going to change the way we practice, and how are we going to change the way we teach medicine? As the leader of one medical school told me, we'd like to teach this new kind of medicine, but we can't do that until all the practicing physicians agree with it. And of course, they won't agree with it until we teach it. So we really have a catch-22 there. So as everyone knows, who has either sent someone or referred someone to a center of excellence or to a standard expertise area with the Alzheimer's center of excellence, et cetera, it really is a sad state of affairs. The patients will often wait. Everyone's been told there's nothing to do, and therefore why go in early? They're just going to tell you something bad. One of the things that happens, as you know, is they take away your driver's license. They make it so you can't get long-term care insurance. So people wait and wait and wait, just the opposite of what is critical to do. And then of course, they ultimately go to a primary care provider who says, I don't need to refer this person. I don't need any expertise. I can write a prescription for Aricept just as well as anybody else. And then of course, things go downhill, downhill, downhill. And finally they say, you know what? Things are tough now. We better refer you to an expert. And of course, the expert says, look, I can't help you. I'll make sure you don't have your driver's license, that you can't get long-term care insurance. But do you mind coming back every 6 months for a spinal tap so I can renew my grant? That's how bad things are, unfortunately, these days. So this is looking at the various drugs that have been declined. And in one decade, there were 244 clinical trials, 243 failed. The one that succeeded had a very, very minimal effect. And so we keep going through this sort of thing. And as I mentioned, aducanumab is just the most recent. Now, what's interesting about aducanumab, it could still be approved, despite the fact that the impartial group of experts strongly recommended against approving it. The FDA has until March of next year to determine whether it will be approved or not. And interestingly, the Alzheimer's Association is pushing for approval. People say, we just want something. So even if it doesn't work, we want something. So this is like saying, I know this parachute doesn't work, but I'd still like to wear it on the way down. And I'm willing to pay $100 billion for it. As they say, any drug that is going to be significant one for Alzheimer's is probably around a $100 billion drug. Even you look at things like Aricept, which have a minimal effect, that was selling over $2.5 billion per year. So we'll see what happens between now and March with the FDA and aducanumab. So I think everyone here knows we need a paradigm shift. We need to step back. We need to look at the way we think about these neurodegenerative illnesses, and indeed all complex chronic illnesses. We need to look at the way we're evaluating them, preventing them, and treating them. And I think everyone here has had the experience that there actually is a lot to be done. So let's just compare the research findings with the current standard of care, and you can see immediately why this is an issue. So the current standard of care, we hear this all the time. We don't know the cause of Alzheimer's, as if there's only one. It's some disease, we have a treatment, it's a monotherapy with a drug, and it's ineffective. In contrast, what the research shows is something quite different, that there are dozens of things that contribute to this, just as there are to heart disease, cancers, and other complex chronic illnesses. That there are multiple different subtypes, and we've described 6 different subtypes, and we'll talk about that in a few minutes. And therefore, there are many personalized precision medicine programs, protocols, depending on what's actually driving this. Root cause medicine, as you've heard again and again and again, and that's what it needs to be for these diseases as well. So what that means is the perfect Alzheimer's drug would have to be more than just an antibody to the amyloid beta. It would have to do this, because you've got a lot of different things that are actually contributing to your cognitive decline. So a little follow-up, a number of people have asked me about patient 0. She was the very first one who came to see me in April of 2012. She's actually doing very, very well. She's actually now just turned 77. She's working without problems. She went off the protocol 4 times, as I mentioned in the book. Each time she experienced decline within 7 to 10 days. So we used to think maybe because amyloid, if that was the big problem, then maybe when people got rid of this, when they did the right thing, maybe they'd be able to go a couple decades with no medicine. It just doesn't turn out that way. This is a dynamic system. Your ability to make and store synapses, no surprise. Neuroplasticity is plastic and dynamic. And so when people stop doing the right things, within about 7 to 10 days, they begin to show some decline. And some people even notice if they just go from ketosis to non-ketosis, that they'll get some degree of brain fog. And as you know, there have been so many things where there have been parallels between COVID-19 and Alzheimer's disease, very many of the comorbidities, of the risk factors, and even the overall concept. So people have asked many times, why is it that amyloid, you're claiming that this stuff is actually protective, but we also know that it can be destructive. You make too much of it, it puts you in a synaptoclastic state instead of a synaptoblastic state. And there's a great parallel with COVID-19. So you have an insult, in this case, it's SARS-CoV-2. And so what happens? We're told to shelter in place. We're told to do social distancing, do the things we're doing now with Zoom, et cetera. And so we end up in a recession. So this is a protective downsizing. And this is exactly what's happening with amyloid in your brain. This is a protective downsizing. The amyloid has been shown by Rudy Tanzi and Robert Moyer. This is an antimicrobial. So this is protecting your brain. On the other hand, yes, it is also downsizing. You are in a protective downsizing mode. So it's up to us as physicians to find out what are those insults that are putting each person into this mode, and therefore we can address these. And one of the things we found over the years, and we have a lot of information with now over 5,000 people going through the protocol, that it is deceptively difficult to do the right things. There are a lot of people who are practicing it poorly because they don't know which are the most important items, the prioritization, and which are the least. And so they'll be focused on something that's not the most important thing. So the critical nature here is to figure out what the priority, what are the critical things that are actually driving the cognitive decline, or hopefully risk for cognitive decline. I'm really convinced that if we could get everybody on prevention, we really could have a huge impact. We haven't seen anybody yet who's gotten on appropriate prevention and then developed dementia. Now, obviously, it's early days, so we'll see. but that's the way we've seen so far. So here are just a couple of examples. This is a guy, Edward, not his real name, who has done beautifully. It came to see me in December of 2013. And you can see just dramatic improvements in his auditory delayed memory, his reverse digit span, his CVL2, CVLT2, et cetera. He's done very, very well. Now coming up on 7 years on the protocol. Here's another one, Marcy, and she interestingly has had both improvements in her hippocampal volume and improvements in her FDG PET scan. So her PET scan went from showing Alzheimer's to showing non-Alzheimer's. So very enthusiastic about that. And her cognition, she's done multiple different assessments of her cognition and done much, much better, as you can see here. So here's a 66-year-old guy with senior moments. Family history, strikingly positive, both parents, and very good documentation. It was interesting because his wife said, you know, everybody his age has a little issue. It's no big deal. And we said, well, wait a minute, you know, look at the test. His FDG PET is markedly positive. His amyloid PET is markedly positive. So yes, you may feel that his symptoms are mild now, but he's really headed for some very bad times and already well into MCI. This guy, you can see why, you know, as a functional medicine physician, you can see why this guy was struggling. This guy actually is a brilliant physician himself. Very high hsCRP, high homocysteine, low vitamin D, low testosterone, low free T3, slightly high TSH. So lots of reasons. This guy responded absolutely beautifully, metabolically, cognitively, volumetrically. His neurologist said he's back to normal, and he's done very, very well. And by the way, this guy sometimes will cheat and also has problems when he does so. And you can see his MRI hippocampal volume, just dramatic improvements here. You can see also his gray matter increased by 23% in his gray matter. So striking improvements. So there really is a lot of plasticity there. And again, you know, the earlier, the better. Here's a 62-year-old woman who presented with dysnomia, executive dysfunction, and also ApoE4. Of course, there are 75 million Americans who are ApoE4 positive, so about a quarter of us. And most, of course, don't know it. If you have 0 copies of ApoE4, your lifetime risk for Alzheimer's about 9%. It's not 0, you can certainly get it, but it's not terribly high. If you have 1 copy, it's about 30%, so of course much higher. If you have 2 copies, it is somewhere between 50 and 90%, depending on your other genetics and depending on the published studies. So very, very high. It's more likely that you will develop Alzheimer's during your lifetime than that you will avoid it. So everybody should know. And in fact, again, you go on the standard line out there from the various foundations is there's no need to check this because there's nothing you can do about it, which I think, you know, borders on negligence. This is just so sad. We should all know our status, just as we want to know our blood pressure, our cholesterol. Telling people there's nothing you can do about it, I think, is really goes against the published data. There's a lot to do about it. And in fact, it is different whether you're ApoE4 positive or negative in what you're going to do about it. Of course, they handle lipids differently, as I'll show you. The genetics, the effects on DNA are actually different. The inflammatory status is actually different. So it's actually good to know what your status and not to be afraid of it. There's a tremendous amount you can do. So this particular person, as you can see, had a fairly good BMI, but high fasting blood sugar, high hemoglobin A1C. So this person was pre-diabetic, high fasting insulin, had a high HOMA-IR, et cetera, et cetera. You can see also inflamed hsCRP of 1.7, low vitamin D, slightly high TSH, and so forth and so forth and so on. Pathogen testing was negative for tick-borne and herpes family vectors here, and then went on, you know, the protocol did the various pieces and addressed the various things and actually has done very well, improved her metabolic and cognitive status over 12 months, and her MoCA went from 20 to 28. She was able to run her business once again. These improvements are striking in many, many people. So we've been interested for years in the fundamental molecular biology of what's actually driving the process. What is Alzheimer's disease? I actually used to go to various Alzheimer's meetings with hundreds and hundreds of other researchers and say, we want to know what is Alzheimer's, and people would like, what are you, crazy? What do you mean, what is Alzheimer's? It's Alzheimer's disease. Well, we want to know what is actually driving this. Why do you get this? Why is it so common? Why has it been so hard to treat? How can we do it better? And does it give us any insight into other neurodegenerative diseases, from macular degeneration to Lewy body disease to frontotemporal dementia to ALS? These are major issues. So what we found is at the heart of this, and of course, spent my whole career being a reductionist until we finally got to see that APP is not a reductionist molecule. In fact, it interacts with many, many other things. And so this amyloid precursor protein, which sits here, and you can see here, it's a type 1 membrane protein. So here's the amino terminus outside the cell. Here's the cell membrane. Here's the carboxy terminus inside the cell. And this is a really, really interesting molecule. And this is the one, of course, that the amyloid that we associate with Alzheimer's disease comes from. So what happens is there are many interactors with this. When things are good, this will sample your hormonal levels. And as an example, you can trace directly the interaction between estradiol and APP. Estrogen binds to its receptor, of course, goes into the nucleus and affects hundreds of genes. And one of the genes it affects is the one that actually comes out here and cuts the APP right here. And so you now get these two fragments, these two peptides, and these things actually are supportive. These tell you things are good. We're going to be able to make and keep new synapses. And as you can see here, these are like two memos going out from the president that say, okay, here's one for the public, here's the one for internally. They both are saying things are good, grow and make new synapses. And you can also trace, other hormones and things like that, growth factors signal through this, etc. And so on the other hand, when things are bad, if you have reduced nerve growth factor, reduced brain-derived neurotrophic factor, reduced vitamin D, reduced estradiol, progesterone, or you have ongoing inflammation, and again, you can trace the pathways. NF-kappa B, of course, enters the nucleus as well. Hundreds of genes are changed, and one of the things that happens is you increase both this cleavage and this cleavage of APP. And so what that's saying, again, it's just like COVID-19, things are bad. We need to shelter in place. We need to pull back, and we need to protect ourselves. So everyone has been focused on this guy right here, this amyloid, but in fact, it's part of a much bigger story. And again, it's protective. So we don't want to remove the amyloid as long as you have the ongoing problems. We want to get rid of the ongoing problems. We want to know what's the cause, the contributors of Alzheimer's, not the mediators of Alzheimer's. And what people have been talking about as the cause, tau, A beta, inflammation, all these things, these are the mediators. We want to know the upstream, the things that activate, that begin this process. So you can see here these three cleavages. Now you've got two things outside and two things inside that are telling you things are bad. We need to be in protection mode. We need to kill the advancing microbes. We need to bind the toxin metals, which this also does, and we need now to pull back. And we're going to function in a smaller brain, but we're going to survive. So it's a very different way to think about these neurodegenerative diseases, and it means that we have to evaluate them and treat them quite differently. So we first looked at transgenic mice and looked at, okay, could we change that balance with APP? And you can make a single mutation in a transgenic mouse, and you can change that balance. And we found out that, yes, when you do that, in fact, the mice keep their cognition much, much better. So then we wanted to know, okay, well, what if we tried to take this to a human? With a mouse, it's easy. We change the gene. But what do we do with humans? Well, it turns out that many, many things, many pathways converge on this APP. So you can see here, this is a central gate. This is a node that is saying, okay, I'm responding to your estradiol, to your nerve growth factor, to your BDNF, to your NF-kappa B, all these things. It is very much of a functional medicine node. Therefore, we need to be cognizant of that, and we need to measure these various things that are actually driving the APP in one direction or another. We know that everybody who has cognitive decline, who associated with Alzheimer's, and that's the majority of the causes of dementia, then all of them are on the wrong side of that balance because they're making the A beta. And by the way, the A beta is part of the innate immune system. So again, there's another really interesting parallel with COVID-19. What do we see with COVID-19? People are dying of cytokine storm. So what happens is you've got the innate immune system on full active, but your adaptive system has not succeeded in clearing the pathogen. So you've got to knock that down. You got to play the game of, wait a minute, we can't do too much. If we have too much suppression with continued exposure to COVID-19, that's not a good thing either. But we've got to make it so that you can survive this. Alzheimer's patients, it's the same, but instead of a cytokine storm, it's a cytokine drizzle. So what happens is you have this long-term activation of the innate immune system. And in fact, people who have Alzheimer's typically have, and that's the A beta, that's the innate immune system, but they often have a poor response of the adaptive system. And what are some of the reasons? Because they have too low omega-3s. That turns out to be critical for your adaptive, because they have too low vitamin D, all the things that help us with the adaptive system. Of course, zinc, another one. And of course, these people often have low zinc. So that same problem of a mismatch between the innate system and the adaptive system is a problem in COVID-19, and it's a problem with Alzheimer's. And let me just put this in perspective for a moment. We're looking at hundreds of thousands of people dying from COVID-19. So if you go back to who was alive at January 1st of this year, by the time COVID-19 is over, there are predicted to be something like 500,000 people that die. We're more than halfway there already, so it may be more. But the number of people currently living who will die of Alzheimer's disease is about 100 times that of COVID-19. So it's about 45 million of the currently living Americans. Yes, we always hear the term 5.5 million people have it, but of course, many people too young to know. Our two daughters, for example, too young to know. So if you look at all currently living Americans, about 45 million of us will die of Alzheimer's. So it is a huge problem. It is another pandemic, but it happens to be a slower pandemic compared to the COVID-19 pandemic. So again, as we've talked about before, this really gives us a new model where we're saying, hey, you got to address all these things, and you got to know the ones that are critical for Alzheimer's. For Lewy body, it's a different set of holes. For Parkinson's, it's a different set of holes. But if you know the neurochemistry and the genetics for each of these, you can know what to look for, what are the high priorities, what are the low priorities, and address those things. And of course, the earlier the better. So one of the most important things is for people to realize, wait a minute, there is something that can be done about these things. We cannot wait. I can't tell you how many times people will come and their family will bring them in and they say, well, we knew there was nothing to do, so now the person's had this for 8 years. No, there's a lot to do, and we want people to get either on prevention or the earliest reversal possible. So I mentioned here the ascending rate limiting steps, because as we've been going along, one of the things that we've found is that people will often improve and then plateau. And you have to look at, okay, what's the rate limiting step that's stopping you from getting that higher plateau? Many times people will have one thing going right, but maybe another thing's not going right. And so it's important to look at what is the rate limiting step for each person so that we can continue to optimize. The good news is when you find it, people will get yet another bump up. And I have an example to show you in a few minutes about a person who did very well, but then plateaued and actually started to decline a little bit, then found what that rate limiting step was and did extremely well. So I showed this one before, so I'm going to make this much quicker this time, but it's important because it's related to why people get this. About 2/3 of people who have Alzheimer's disease are ApoE4 positive. Now that means 1/3 of us are ApoE4 negative. But many, many who have it. And it's kind of the canonical Alzheimer's disease gene. There are dozens of genes associated with risk for Alzheimer's, but the most common one that everyone's aware of is ApoE4. And as I said earlier, about 75 million Americans actually have one copy. About almost 7 million Americans have two copies. And again, the vast majority don't know it. So we knew years ago, and this was a 10-year project, we knew years ago things start out with ApoE4 for many of us, end up with Alzheimer's disease for many of us, but it had not been clear what's in the black box. And the party line was always, it decreases your ability to clear amyloid. And yes, it does that, but it has many other effects as well. And so we started a project to look at what actually is going on. And to make again, a 10-year story very quick, ApoE actually binds, not just E4, but also E3 and E2. These bind to specific receptors on cells. And in fact, that had been shown before. There are several different receptors that bind ApoE. What hadn't been appreciated is that it then interacts with REL-A, which is part of NF-kappa B, and enters the nucleus. And it's not all, and that's why it had been missed before, it's not all of your ApoE4 that enters the nucleus. Somewhere around 10% or so, but a substantial amount gets into your nucleus. And it's really striking. And I should say this work was pioneered by Dr. Ram Mohan Rao, who worked with me for 20 years, fantastic guy. And what Ram showed, and his whole group showed, was that there are 1,700 different gene promoters that bind ApoE4. And a lot of people pushed back at the beginning and said, no, it can't be. And more recently, another group has shown by a completely different technique that yes, indeed, ApoE interacts with DNA. And interestingly, it acts as a suppressor. So it actually decreases the transcription from these various genes. And one of them, by the way, SIRT1. And so if you now group these genes, in fact, what you see is you could not tell a better story for Alzheimer's disease. These are genes associated with inflammation. It actually decreases genes that decrease inflammation. So you end up with a net increase in inflammation. It decreases some of the neurotrophic activity. It decreases SIRT1, which is critical for longevity, of course, but also for it having an anti-Alzheimer's effect. It impacts synapse function, it impacts glucose homeostasis, microtubule disassembly. So it's a remarkable story. It really is something that changes. It's literally changing the programming of your cells. Now, it's not to say that one's better, one's worse. So all the people in hominid evolution, 96% of our evolution, we were all ApoE4 homozygotes. It was only in the last 220,000 years, ApoE3 appeared, and then in the last 80,000 years, ApoE2 appeared. So this is something that is allowing you to live with uncooked meat. It's allowing you to live with various pathogens. If you're in a third world country, you will live longer, healthier if you're ApoE4 positive. On the other hand, if you're not in an area with uncooked meat and things like that, you do tend to live a little longer with less inflammation if you're ApoE4 negative. Okay, so fine. There's now a whole wonderful website set up by Julie G, who herself is an ApoE4 homozygote, who's actually been on the protocol here for over 8 years, and she's done very, very well. And she set up a wonderful website called apoe4.info. There are over 3,000 people who share their information, share their approaches, et cetera, and are doing very, very well with their own prevention. And they can basically change the way that they're living so that they do much better. For example, you're going to want to fast a little longer, for example. You're going to want to be a little more careful about saturated fats, things like that. But you can keep that inflammation down and do exceedingly well. So what this shows is a little bit like North and South Korea, a little bit. You've got an ApoE4. This is a REL-A dominant system. It's a pro-inflammatory system. And interestingly, REL-A and SIRT1 have 9 different areas where they inhibit each other. So there's cross inhibition. You either tend, it's essentially like 2 different modes. You have a mode that is more pro-inflammatory. You have a mode that is more SIRT1 dominant, more metabolic and longevity supporting. And ApoE4 tends to push you a little more toward the REL-A side, and ApoE3 tends to push you a little more toward the SIRT1 dominant side. Now, what that means is if you're ApoE3 and ApoE4 negative and ApoE3 positive, then you've got to be more careful. You're going to have more trouble if you eat raw meat full of microbes. You're not going to do as well if you get an infection because someone stabs you with something, things like that. So you've got to be careful. So as you know, the standard of care has been just horrific when it comes to these neurodegenerative diseases. I think we'll look on this, these as the dark ages. It's truly barbaric what we're doing here. So you wait for the symptoms to appear. That's the first thing that's wrong. We want to get everybody, there should be, just as we had global programs for vaccination against smallpox and polio and things like that, so too should there be global programs to prevent people from having cognitive decline. This is a huge problem. Of course, when you do get symptoms, people often wait, then they go in, they see the doctor. The doctor is limited by the system he or she works in. The patient is supposed to be passive. Anything if the patient brings in and says, what about this, what about that? The doctor gets upset about that and says, I'm the doctor, don't tell me what to do. The involvement is seen as just interference with the doctor's job. The doctor gets a very tiny data set. Typically, they look at sodium, potassium, the typical sorts of simple things, and then they'll look at B12 and TSH only for the thyroid, which is crazy. And they don't have any algorithm, any way to approach this. They just say, okay, you have Alzheimer's, there's nothing we can do. I'm going to give you a drug. It's not going to work very well. Get your affairs in order. Of course, at that point, you can't purchase long-term care insurance. You've also just lost your driver's license. You go to a nursing home where you spend about $100,000 a year. And by the way, the average cost for anybody with Alzheimer's before they die, about $350,000. So it's a huge problem. You destroy the family's finances and you die destitute. So that's the current standard of care for Alzheimer's disease. So we want to change that, obviously. We want to make it better. And so we want to have active prevention programs. And if anyone begins to have symptoms, by all means, come in as soon as possible. People who have SCI, and you go from asymptomatic or pre-symptomatic to SCI, subjective cognitive impairment, 100% of those people get better if you do the right things. Then if you don't, that lasts about 10 years. If you don't do something, then you go into MCI, and most people with MCI can get better. These are people where now they're testing abnormal, like the one I just showed you who had the MoCA of 20 to 28. She was kind of bordering on late MCI, but she's done very, very well. So you want to optimize things at that time, and we want to have prevention and reversal and optimization. And then we want to have a central coordination because all of these things work together. One of the things that we're really lacking is dementia insurance. There should be dementia insurance so that people can get this early on and say, look, you're gonna make sure that I never get demented, and literally take a test once a year. And as you start to, if there's any fall off at some time, boom, you want to jump in, have an active program so that you don't let people come in when they've had 8 years of dementia. You get them before that and you can help them. You want to have expert systems. It's interesting to me that we have such amazing systems for things that will tell us where people are shopping and know everything about them so that they can sell more to us. But we're not using that sort of sophistication to prevent and reverse neurodegenerative disease. That's crazy. We need to have these sorts of expert systems and larger data sets to get better outcomes. And as I mentioned, active insurance, where the current, as you know, long-term care insurance currently, what they do is they sell you this insurance, and then they simply say, well, if you have a long-term problem, you have chronic problems, and dementia is the big one, then we'll just pay. Instead of saying, we're going to work with you and make sure you never get dementia. That's the goal. Of course, the other thing is, when you treat someone, you give them a prescription and that's it. You just say, okay, goodbye. We want to continue to optimize. And what we've seen is people will continue to get improvements as they do that. And we want to reduce the global burden of dementia. This is $1 trillion problem. We want to combine all these things basically to produce a better system. That's the idea. And I really liked what Eric Yuan from Zoom said about making people happy. We want to make people healthy, obviously. So what do we do this? How does this work? And I know a lot of people here have done this with people and have done this sort of approach with their own patients. So we want to determine what stage is this person pre-symptomatic. It's important to note that there is a long run-up where people are completely asymptomatic. And yet, if you look at their amyloid scans, they already have amyloid in their brain. It is part of the innate immune system. It has a long half-life. So it'll already be there. They can already see that the cerebrospinal fluid is abnormal. So there's a long run up. We really have an opportunity for what would be secondary prevention. And then if you don't do anything about that, then many people will go on to SCI, where you have subjective changes, but your cognitive tests are still within normal limits. Now, again, for many people, it's just because the tests are too easy. We get that. So SCI and MCI are really part of the same thing. Just depends on how hard your tests were. But the interesting thing is you've got a decade often. That was the average length in one study of SCI was 10 years. So you have a long time to intervene, get people doing the right things, and virtually all of those people respond. Once you go on to MCI, not all of them respond, but many of them do. The majority do if you get them and do the right things. So in this case, you clearly have problems that can now be measured on cognitive scores. About 5 to 10% of those people convert to dementia, which by definition means they're beginning to lose their ADLs, their activities of daily living. Now think about that. That is so late in the course of this neurodegenerative illness that what we call Alzheimer's disease, by the time it's truly beyond SCI, beyond MCI, Alzheimer's, that's like saying someone has widely metastatic end-stage cancer. That is a very late process, and typically it's about 20 years before you go from the beginning of the pathology to Alzheimer's. So once your ADLs are affected, that's Alzheimer's. Still, many of these people will do well, but it's much harder, as you can imagine. So then we want to know what subtype. Type 1 is inflammatory or hot. Type 2, atrophic. Type 1.5 has some of both because it's got some that is inflammatory due to the glycated proteins. And it's got some that are insulin resistant. So you've got some decrease in insulin signaling, and insulin is a critical trophic factor for the brain. So you get a little of type 1 and a little of type 2. And this is a very common feature, this glycotoxic, and something that you can do a lot about, of course. And then toxic. This is the tough one. People who have exposure to these various toxins, these metallotoxins, all the inorganic toxins, the whole thing with the fires in California, this is a real concern for a future increase in dementia. If you go to what happened in World Trade Center, the people who responded there, these people just between 2001 and 2015, 13% of these people already had cognitive decline, even though many of them were still very young. So this is a huge problem. And anytime you have massive exposure to air pollution, to fires, to World Trade Centers related pollution, all these things, you increase your risk for cognitive decline. So everybody who is in the fires, with basically all of us exposed to the poor air quality, should be on active prevention. Type 4 vascular, and this is very common. This is reduction in energetic support for your neural network. And then finally, type 5 traumatic. So you can determine which of these different people fall into. And of course, many of them will have some degree of multiple of these. So you've got to ferret that out. So the goals for treatment and prevention, this is the critical piece. So we want to understand for different people. So I've put these in roughly descending order with the understanding, yes, for different people, the order is going to be changed. But as a general order, if you don't take care of the things at the top, we're in trouble. So energetics, if you're looking at what happens in a brain that is trying to keep its 500 trillion synapses and is now in the midst of downsizing, it's not going to stop downsizing as long as it doesn't have enough energy. And that means a combination of cerebral blood flow, oxygenation. So many people have nocturnal desaturation, hear it all the time, and correcting that is often helpful for people. Ketosis, getting, as Stephen Kinane has taught all of us, Yes, when you have Alzheimer's, you have that PET scan that shows decreased utilization of glucose in the temporal and parietal regions. So one way to bridge that gap is to get ketones in there. And we want to go for 1 to 4 millimolar beta hydroxybutyrate. Yes, it's a workaround, but we're trying to get enough energy for people to have synaptic function. If you like to use a breathalyzer, and there's a nice one out now from Biosense. I don't work for Biosense or get anything from Biosense, but this is they've made a really nice, I think, a really nice breathalyzer that allows you to look at your acetone levels. They measure it as ACEs, and you want to keep above 7, preferably even above 10. That correlates to about 1 millimolar beta hydroxybutyrate. It's about a 8 to 1 or so. So you want to get a substantial amount of this. All of these things are critical. Cerebral blood flow, getting people to do things like EWAT and getting them out and exercising turns out to be critical. And of course, so many of these people have vascular disease that has to be addressed as well. So that's arguably the top priority. Second thing is insulin sensitivity. And Professor Ed Getzel did some really nice studies published a few years ago showing that if you look at neural exosomes, so you're literally looking at what's going on in the brain of people with Alzheimer's, virtually 100% of them have insulin resistance. So it is a common player with this disease. So getting them to be insulin sensitive. And again, as I mentioned, not only is insulin critical for metabolics, but it's also critical as a trophic factor. When we used to grow primary neurons in a dish to study them, we always had to include insulin in their feeding so that they would stay alive. And then, of course, trophic support, growth factors, hormones, nutrients. Not only do you have to have appropriate oxygenation, mitochondrial function, cerebral blood flow, and energetics with ketosis and those sorts of things, but of course, you've got to have appropriate hormones, nutrients, and trophic factors. If your BDNF is very low, you're at increased risk for cognitive decline. If your NGF is very low, same story, and on and on. And again, if you've gone through early menopause or early oophorectomy, as the group from Mayo Clinic showed a number of years ago, if you had an early oophorectomy, and by early in this case I mean 40 years of age or younger, and you did not have HRT, then you doubled your risk for Alzheimer's, even though the Alzheimer's was diagnosed many, many years later. So trophic support, huge, and there's, again, so many things in the arsenal. The arsenal for cognitive decline, which we've always been told is nothing but Aricept and Namenda, is huge and growing. Resolution of inflammation. Again, as Charles Sirhan has taught us, it's not just about an anti-inflammatory, it's also about resolving the inflammation that's already there, whether you like to do that with SPMs or high-dose omega-3s or whatever you like to do, that's critical. And then understanding, and I think the most important point of all here is we often think about, yeah, we got to reduce the inflammation, but we also have to figure out, why does this person have inflammation? Is it metabolic syndrome? Is it leaky gut? Is it chronic sinusitis? Is it an undiagnosed pathogen? Is it SIRS? What is causing this ongoing inflammation? Because as long as it's there, as long as you're activating the innate immune system, you're going to make more amyloid, you're going to have continued cognitive decline. And then, of course, treating the various pathogens. And it's been amazing to me, of course, when I was in medical school, we were all taught that you want to have sterility, you want to get rid of all these bugs, instead of, no, there's really a microbiome and you got to get the good bugs and not the bad bugs. So things have really changed, but it's amazing to me how many of these chronic pathogens can live within us for years. And we end up with things like cognitive decline or rheumatoid arthritis or what have you, without addressing those. And so, we see this all the time. Someone will have something like babesia, and they've had it for 10 years because we know when they got the tick bite because they had Lyme at that time and they got treated for the Lyme, but they didn't get treated for the babesia. Now, 10 years later, you've got to have that treatment to get them optimal outcomes from their now cognitive decline. And then, of course, detoxification. I already mentioned the concern about air pollution. And then organics. We're seeing a number of people, whether it's glyphosate, whether it's formaldehyde, whether it's toluene, benzene, We had one person who developed a primary progressive aphasia associated with Alzheimer's disease due to long-term exposure to paraffin candle burning. Or, is it biotoxins? Do you have trichothecenes or ochratoxin A or gliotoxin or things like that? And then stimulation. It's really interesting that people who've done the best have tended to include either light stimulation, magnetic stimulation, brain training, of course, another excellent way for stimulation, but some form of stimulation, but not overstimulation, because stress, of course, also a risk factor for cognitive decline. And then, as I said, improving the adaptive side and reducing the innate side, just as you need to do with COVID-19, you also need to do with Alzheimer's and pre-Alzheimer's. And then, great, remove the amyloid after you've done everything else. After you've removed the cause of the amyloid, hallelujah, get rid of the amyloid. But this idea of using a monotherapy and skipping all the earlier things and just saying, yeah, whatever's bothering you, we really don't care, we're just going to remove your amyloid, it actually doesn't make theoretical sense. Now, that's not to say it won't ultimately work. Maybe someone will come up with a new anti-amyloid drug that'll be fabulous, and we'll be wrong about this. But at least theoretically, and from what we've seen so far, it doesn't make sense. And I'd be very interested to hear from anyone who's seen what we've seen repeatedly, which is people who went on those monotherapies, removed some of their amyloid, and that was shown by follow-up PET scans, and got worse. And in fact, the pattern was striking. Each time they would get an injection, they would get much worse, and they would slowly come back. So something happens at that time, and then they'll slowly sawtooth down with each of these injections. They'll slowly come back to almost to where they were. Then they'll get their next injection. So my concern is that if you're not addressing these other things, you may actually be doing yourself a disservice. I actually think that these drugs are going to be very valuable when we remove the other problems first, and now we want to remove that amyloid. And it's not such a risk to do that. I think that they're going to be very, very helpful when used in that way. And then, of course, ultimately, when you've addressed these other things, you've stabilized people, you've begun to improve them. Many of them have lost many synapses already. And so regeneration and synaptogenesis, and there are many approaches to this. And of course, stem cells, the obvious one. Again, there are ongoing trials for stem cells as a monotherapy. This is like trying to rebuild a house as it's burning down. Let's put out the fire first and then rebuild the house. And then there are all sorts of things like intranasal trophic factors and things like whole coffee fruit extract, and even the effects of hormones and things like that to support synaptogenesis. So these are the basic things that we want to be able to address. And for different people, it's going to be different ones. Some people will have a lot on the inflammation. Some people will have specific pathogens. Some people, the toxins are the main issue. Some people, it's the vascular status, but we want to figure that out and address that. So to take care of all these things, and look at this, we produced a mobile app. It's called Recode app. How are we doing on time here? Okay. So we produced this app that will look at these different things so that we can keep track of all these different things. And I think this is the future, to have these computer-based algorithms and to be able to look at how we can optimize. And also that will help us collect data. So now, you check your ketones, we'll be able to see it on here. And so that now we'll be able to see, who's doing the best, who's doing the worst. And ultimately AI is going to be what's going to give us better and better approaches to these sorts of diseases. So energetics, we talked about, ketosis, blood flow, oxygenation. I won't go through all these things because I think there are many experts here who know far more than I do about much of the functional medicine here. We're simply trying to get the outcome here. The goal is improve the neurochemistry so that you are on the synaptoblastic side of APP rather than the synaptoclastic side of APP. And of course, for those who say, well, yeah, just get a drug that just prevents you. Yes, that's been tried, and your brain is too smart for that. You just inhibit that one enzyme, it turns out your brain just basically goes around that, and you still have cognitive decline. So in fact, your brain is a little too smart to just try to try to impact that one enzymatic step. On the other hand, again, that's going to be great for when you're doing everything else. And so again, I think these drugs are going to be very powerful when used in conjunction with a functional medicine approach. So lots of things you can do for energetics. I mentioned the ketosis. The diet we use is called KetoFlex 12-3. It is a plant-rich high fiber with appropriate fasting. All of these things, again, are critical. I am not a nutritionist. I'm just trying to drive your neurochemistry to what is optimal for your brain to keep its synapses. Lots of interesting things. I don't know how many people here have tried katsu, but a lot of people have had nice results with that. Iwa, this is something where you use this comes from Japan, of course. It's where you use bands. So you essentially get more bang for your buck. And especially for the very elderly, this has done very, very well. EWOT, exercise with oxygen therapy, again, a way to enhance support, especially the oxygenation for your brain. Strength training, huge, of course, for insulin resistance. And then sleep. So many people have had poor sleep as one of their problems. It's even something where people say, well, you know, I don't get much sleep because I stay up and work really hard and all this sort of stuff, but that's, of course, really hurting you. I think with all the quantified self that's around now, oh my gosh, it's been fantastic. So people using Oura rings and the new Apple watches and better, you know, to check your SpO2 and checking heart rate variability and checking their own ketosis and their own microbiomes and their own dysbiosis and their own telomere lengths and on and on and on. I think that there's so much now. People will be able to look at these. And again, this is the whole way to defeat chronic illness, for all of us to look earlier so that we can make changes instead of waiting till you're very, very late in the course. Interestingly, with respect to stress, we have people who literally their cognition goes you know, as the inverse of their stress. High stress levels, cognition is not particularly good. When their stress levels are low, their cognition is clearly better. And then, of course, you know, cerebral blood flow, optimizing that. And there are all sorts of things, again, from nitric oxide, you know, from beetroot juice and all these things. And then be careful. There are some people who will have a thrombotic tendency. And this has really come out, as you know, with COVID-19. This is one of the ways that people die. Is with microinfarcts in multiple organs, as they say, you know, in the heart, in the brain. This is a major problem. And so for those who do have this, and a simple example is picking this up, for example, on Intellex DNA, which was set up by Sharon Houseman-Cohen. I think this is a nice way to look, but there are, of course, other ways to look. You want to know if the person has that propensity. Then consider things like pycnogenol or nattokinase. We had one guy, for example, seen by Dr. Anne Hathaway, just a fantastic integrative physician that I know many people know, who noted that this guy, when he would get on a plane, would actually get much worse. And he turned out to having a thrombotic tendency and did much better when she treated him with pycnogenol and nattokinase. Oxygenation, again, we should be sitting at 96 to 98%. We have people dropping into the low 70s who never bothered to check. And when you check, you find out, wow, this is a huge problem. And fixing that is critical. And we see people who, of course, again, this is something that came up with COVID-19. How good is your oxygenation? And then, of course, mitochondrial support with things like ubiquinol, nicotinamide riboside, PQQ, the ketones themselves. And I think methylene blue is really turning out to be an interesting possibility. Of course, Dr. Francisco Gonzalez Lima has done some beautiful work on methylene blue. We'll see as time goes on how much help that provides for people with neurodegeneration. But I think he's got data to suggest that it's very promising. So how do we achieve these goals with insulin sensitivity? Of course, again, people here are excellent with that. So it's getting people strength training because the muscle is very rich in insulin receptors, getting them on appropriate fasting, appropriate diets. It's interesting to me that there's, of course, a whole group of people interested in purely carnivorous diets. And, you know, again, we're agnostic, whatever works. There's been nothing published saying that helps cognition yet. But people have experienced improvement in autoantibodies, and improvement in autoantibody-related disease, autoimmunity. So who knows, for people who have autoimmunity as one of the drivers for cognitive decline, that may be a way to go. But in general, everything that's been published so far and what we've seen as well is that you're looking for a diet that is a plant-rich, You want to be a vegetarian, fine. You want to be a non-vegetarian, that's fine. But you want to have plenty of fiber, plenty of phytonutrients. You want to have plenty of choline. One of the most common deficiencies, as you know, choline. When I started looking at myself during COVID-19, I found that I was clearly not getting enough choline each day. We should be getting something around 550 milligrams a day. And so I consciously made sure that I had more choline in my diet because, of course, it is the precursor for acetylcholine, which is the most important neurotransmitter for memory formation and is low in people with Alzheimer's on average. So huge issue, a high good fats, intermediate protein, low carbohydrate diet that provides these nutrients and helps you detoxify is typically the most helpful. And that's the one that's been published repeatedly. Strength training, I mentioned, and then of course, many options for support, things like magnesium, zinc. Many of us deficient in zinc, and that has multiple issues. Of course, it makes it so that your insulin is not as effective. It also makes it so that your immune responses are not as sharp. It broadens the curve. You have a less accurate immune response with zinc deficiency. And it's been estimated that about 1 billion people worldwide are zinc deficient. So these things are all critical. And then there are all sorts of things, of course, you can use for supporting optimal glycemic control, whether you like to use Ceylon cinnamon or R-lipoic acid or berberine, so forth and so on. If you use metformin, great. Be careful. There is a nice study showing that people who had been on metformin had an increased risk for Alzheimer's and for Parkinson's. So be careful about that. But there are lots of ways to go here. And then, when I see people early on and we look at their fasting insulin, if they've got a fasting insulin of 20 or 30, I always think, oh, that's good. We're going to make them better and their fasting insulin is going to be coming down. The ones I worry about are the ones that have the high hemoglobin A1Cs, but the low, that just can't make enough insulin. They have the insulin of 1.2, that sort of thing. Now, what happens is, as they get treated with a functional medicine approach, they tend to be able to make more insulin themselves. And as they have appropriate magnesium and zinc and support, they tend to do better. However, some of them have they cannot make it. They don't have the islets left to do that. And in those people, you can, as you know, increase their endogenous support with something like Januvia, Victoza, things like that. But again, wait until you see if endogenous, they can do it themselves. And speaking of endogenous, let me just go back for one moment and just say that it's also true that people, when you're trying to get their energetics optimized, it's fine to start with exogenous ketones. Remember, when they come to see us because they've had cognitive decline, they are in energetic failure. And there was one nice paper that looked at what if you just put them on exogenous ketones versus you got them endogenously ketotic. And actually, for the short term, they both did just as well with their improved cognition. Now, no question, in the long run, the goal is endogenous ketosis. It has other advantages like autophagy and like less inflammation, things like that. But remember that when they first come to see us, they are suffering. They do not have the support for their neurons. So essentially to bridge that gap for some period of time, whether you like to use ketone salts, ketone esters, for people, the idea of using things like MCT oil, be careful if they have vascular disease, be careful if they're ApoE4 positive. So you kind of have to weigh those different options in the long run, then trying to get them on endogenous ketosis. Also be careful if they have a low BMI. They can go backwards trying to do too much endogenous ketosis. And then trophic support, all sorts of things that can be done here. For trophic factors, BDNF is increased by whole coffee fruit extract. It's also increased by exercise. NGF increased by alcar, acetyl L-carnitine, also increased by Hericium erinaceus, the lion's mane mushroom. And again, there is a monotherapy clinical trial with lion's mane, but again, it's part of a much bigger picture. And then there are things like various peptides that can be used. And I do think in the long run, intranasal peptides are going to be so valuable. People already use them as things like VIP, as part of Shoemaker's protocol. But the ability to deliver things to the brain through the nose, as every cocaine addict knows, it's a pretty great way to introduce things into the brain. And small molecules, NGF is a relatively small protein, whereas some of these trophic factors like netrin-1, much bigger, doesn't get into the brain very well. But for these little peptides, it's a great way to get these into the brain. And unfortunately, these have been tried as monotherapies, something called davunitide a few years ago, which is a fragment of ADNP, a fantastic trophic factor for the brain. And I think in the long run, it's going to be a great part of the arsenal, but because it was used as a monotherapy, it really didn't show anything. So then optimal hormones. This is a huge area of controversy. People will say, BHRT. So I won't get into the controversy. I recommend that everyone talk to a real expert, and I'm sure that there's some real experts here. But someone like, whether it's Anne Hathaway or Prudence Hall or whoever you like, or you yourself are an expert, this is something you have to weigh. No question, there are in general better outcomes from cognition if you include BHRT. And then optimal nutrients. And Paul Clayton from Oxford always points out that, our soils are so much poorer than they were even 50, 100 years ago, that most of us are malnourished just eating our day-to-day food. So making sure that you're getting enough of all these things. And then I mentioned earlier, resolution of inflammation, things like SPMs, and then preventing future. And the most important thing, identifying and removing the cause or the causes of this. And then brain stimulation, as I mentioned, things like brain HQ, light stimulation, lasers, magnetics. Some people like to use MERT, and then increasing neurotransmission with things like choline. Some people use nootropics, anything that increases cyclic AMP, which is critical for memory formation. Huperzine A is a way, of course, that's similar to Aricept, basically. So we don't typically use that initially, but something it's part of the arsenal if you've done everything else and you simply need to push up their cholinergic stimulation. Be careful if you push someone's cholinergic stimulation and then suddenly cold turkey it, like with Aricept, people have gone downhill. And then there are things in development such as 40 hertz sound, microcurrent voltage, which seem to be promising. Then after you've done the other things, reducing the amyloid, great. And you can help do that with curcumin. Curcumin actually binds to the amyloid, interestingly also binds to tau, binds to the amyloid quite strongly, quite effectively, and helps to remove it. At doses of around 1 gram, it is also a nice anti-inflammatory. If you go up to much higher doses, still binds the amyloid, still helps that removal, but you lose the anti-inflammatory effect when you're up at 5 or 10 grams a day. Cat's claw, as Rudy Tanzi discovered, also reduces amyloid. Resveratrol, another way, vitamin D, many things which will change that balance. Again, what's really interesting here is your system is deciding between, am I under assault and I need to keep that amyloid around? So what happens is the beautiful assay developed at UCLA by a neurochemist, a guy named Milan Fiala, who's originally an immunologist. And what he looks at is he looks at the ability of your peripheral blood mononuclear cells, so essentially your circulating macrophages, to phagocytose A beta. Everybody with Alzheimer's is not very good at phagocytosing their A beta because they're under assault. They say, no, I'm not. Why would I get rid of my artillery? I'm keeping it out there. When you now start treating, when they start doing better, and he's done this with people who've gone onto our protocol, they now are scarfing this up again, just as normals do. And you can literally follow it. As people are doing the right thing, they do much better with phagocytosing their A beta. When they're doing worse, they do much poorer with phagocytosing their A beta. So I wish you would make that test clinically available, because I think it would be so helpful to follow people with that type of test. So this is where, anti-amyloid antibodies, again, which have failed in the monotherapy trials, I think they're going to be very valuable. And the same for the beta secretase inhibitors. And then high polyphenol diet, things like that also will tip you toward being better with that. And then, of course, removing the source of the inflammation. So we're in the middle of the trial, actually just going to end in a couple of weeks in December. This is 9 months for each person. And so very honored to be doing this with Dr. Anne Hathaway, Dr. Kat Toops, and Dr. Deborah Gordon, three absolutely outstanding physicians. And so this is the first trial in which, instead of predetermining a treatment, which again, if you think about it, makes no sense. You can say, well, all these people have different things going on, but I'm going to treat them all with this Procrustean uniformity to see if any of them get any better. It really doesn't make sense. And so in this case, what we're doing is the opposite. We're looking at everybody first to say, what are all the things that are driving the problem, and then targeting all of those things with a comprehensive approach. It's a small proof of concept trial, just 30 patients, supported by the Evan Thea Foundation, and my great thanks to Diana Merriam and the Evan Thea Foundation for their fantastic support. And the QuestGen CRO that's done a great job, Mike Jarrett and his whole group there. And this compares the protocol to historical outcomes. So interestingly, the IRB would not, after they turned this down over the years, they finally approved it in 2019. And they would not allow a control group, which was kind of surprising to me. But so we have to compare this to historical outcomes. If this looks good, then we hopefully will be able to do the next one with an appropriate control group. Obviously, that's an important thing to do, but unfortunate that we were not allowed to do that at this go round. So we look at the various contributors. So troubleshooting for people who aren't getting better. How long have you been on the protocol? For people who are in 2 weeks, yeah, it takes 3 to 6 months for people to start to get better. What you see is that this happens in 3 stages. People notice that the decline has slowed, then they stop the decline, then they start getting minor and major improvements. So really, if you think about the slowing, it's actually 4 pieces: slowing it, stopping it, start improving, and then improving further. How well documented is the problem? Is it truly Alzheimer's, or is it you're dealing with something completely different? This is optimized for Alzheimer's. For people with Lewy body, this has worked very well as well. That with those people, focus on their toxins. Typically, the Lewy body people have type 3. It's a toxin-related problem. Have you optimized the suboptimal values? Can't tell you how many people said, oh, this is not working. Okay, tell me what your ketone level is. No, never did that. Okay, what about your toxins? Never checked that. Okay, you have to look at these things and optimize those suboptimal. Have you achieved mild ketosis? Are you on a good fats-based diet? How advanced was the process on presentation? No surprise. Earlier, easier; later, harder. One guy wrote me a nasty letter saying my wife had a MoCA score of 0. I put her on the protocol. She got better. She can do all these things she couldn't before. How dare you say that people that need to come in early? Okay, there are some people with MoCA scores of 0 who've gotten better, but they haven't come back all the way to normal. So the earlier you start, the better. The most common problem, lack of compliance. Of course, we want to make this simple, but the disease is not simple. So we're just trying to do whatever we can. We hope with what we'll learn over the years, we'll be able to make it simpler and simpler and simpler. Second most common cause after compliance, as I mentioned, is severe toxicity. And then one of the things is people that just can't be bothered. So we've had a number of people that say, hey, this isn't working. And we say, well, okay, did you do this? Did you do that? Well, I went on a trip for 3 months, so I didn't do anything. Then I came back and I took a couple supplements. Then I did this, but I'm really too busy to do this. You're not going to get better if you do just pieces of it. You really actually have to do the thing. So if the physician is saying, hey, this person's not getting better, do you need a SIRS consultant? That's the hardest part of this, is getting people detoxed. Do they have undiagnosed sleep apnea? That's a common problem. Are they doing regular brain training? That's actually helpful because you can look then and see, are they doing better in their brain training, or they're actually doing worse in their brain training? Are they doing supplements only? Key is to exceed the threshold. Just as Dean Ornish told us all, 30 years ago that, yeah, with cardiovascular disease, you got to get over that threshold to get people better. We see the same thing. Do they have continued exposure? People who are living in their homes with mold have trouble getting better. Are the major underlying causes all being addressed optimally? And then do they have behavior? And as a scientist, I never thought this idea of joy and purpose and stress reduction, I thought all this stuff was silly. And it turns out, I can't argue with the data. People really, it does make a big, big difference. And of course, people are seeing that with COVID-19, more depression and things like that. So yes, giving people joy. They get excited and they want to do this. They start seeing that they're improving and they want to continue. So specific reasons for failure. You didn't identify the contributors. They had reduced SpO2. You didn't get them into ketosis. You didn't get the vascular flow what it should be. Failure to resolve inflammation and remove the source. They had continued stress, continued exposure to biotoxins or other toxins. They still have an innate immune system that's going off the rails. Failure to include BHRT, not using a health coach. The health coaches have been wonderful because they really help people keep going here, and then getting expert input. Some people will doctor shop, as we all know, and just what you finished telling them, they'll go to the next person 2 weeks later and they'll say, don't do any of that. That's a real problem. And then of course, not continuing to optimize. So lessons from the patients. Here's a person who had 4-year history of memory loss, learning difficulties, prosopagnosia, along with mast cell activation disorder, ApoE44, treated with the protocol, did absolutely great from 35th percentile to 98th, but she still had her MCAD, still had hypogammaglobulinemia. And she then started to have some additional cognitive problems because of this earlier prosopagnosia. This is a non-amnestic presentation. We thought, you've got some problem that looks like more the type 3. Do you have exposure to some of these? Finally convinced her after 6 months to get SIRS labs, and they were off the charts. Her TGF beta 1 was something like 40,000. So she then addressed it. It turned out she ended up having babesia, and this was discovered and treated. She ended up, her MCAD got better, her hypogammaglobulinemia improved, and she's done very, very well. So we published several papers on these things, just came out with a second book just a couple of months ago. The first book is really more about the underlying science and how does this all work. The second book, what everyone said after the first book, you didn't include enough details. What websites do we use? What diets do we use? What are the things, what generics do we use? What generics do we not use? So I actually worked with 2 people, one person doing this every day herself, and another one is my wife, who's a functional medicine physician, and said, okay, can you guys help me? Let's make this really practical. So the second one's really about practicality. So no question, this arsenal that we've been told is nothing, is huge actually. And the ability we have to prevent and reverse cognitive decline is far greater than it's ever been. And it's really up to all of us to get this out there and to get people to get as early as possible and to get best outcomes. So as a summary, this really should be a rare problem. Cognitive decline, we know a lot more about Alzheimer's now. It's a protective response to these insults. We need to identify them and remove them. There are multiple subtypes, as I mentioned. These things can be reversed. And we're looking at, what about other diseases now? So we're very interested in what about things like Lewy body, which has responded pretty well actually, but what about frontotemporal? What about PSP, CBD, all these various things, ALS. So we should be able to apply this, and we've just started a project looking at various people that have some of these other diseases. And so we really should be able not only to reduce the global burden of dementia, but to improve the global cognitive ability. As Mike Merznick has pointed out repeatedly, we can all improve our cognitive abilities, and that'll result in fewer plane crashes and fewer various problems. So just as for leprosy and polio, Alzheimer's disease shall become a former scourge. It's going to happen. It's inevitable. It's up to us to do it as quickly as possible and get people out there so we really have an improved global cognitive ability and reduce the global burden of dementia, which is a huge problem. So let me end there. I'm happy to take some questions if people want to do that, or finish up now if that's what people would prefer. And again, thanks very much to Susan and Steve for the very kind invitation.
Thank you for the presentation. It's absolutely fabulous. We're getting all kinds of rave reviews in the sides, and you hit the second highest attendance that we've had.
Great. Well, I hope, I think there's so many people that can be helped. And so I hope that, hope to see that. That would be really fantastic. Hearing, as I mentioned earlier, I'm just finishing a book on the survivors, and just 7 first-person stories from these people who were told that there is nothing to do, who've all gotten better, gone back to work, done all sorts of wonderful things. And there's just nothing better than hearing a human being who got their brain back. It's really great.
I think you'll find that 90% of human beings respond better to stories than actual data.
That's a good point. Yeah, absolutely.
I got a question here about lithium orotate to
Yes.
help prevent Alzheimer's.
Great point. And I didn't mention lithium today, and it's a good point. As you know, it's been involved with things like mood and even things like suicides and murders and things like that. There's less available on its effect on Alzheimer's. And also about, can you get away with 5 or 10 milligrams, these really micro dose, as opposed to, higher amounts. I think, my feeling at the moment is I think it's fine. We haven't used it, and maybe we haven't used it enough. It is, at higher doses, it's a GSK3 beta inhibitor, so it does inhibit tau phosphorylation. So I'd say in people who, especially with tauopathies, it might be something to think about seriously. And I think it's fine to use it. But I do think that what we found so far is that the critical pieces here are the energetics, the inflammation, the insulin resistance, the trophic support. These are the things that are basically telling your brain either I'm under assault or I'm not getting enough support, or no, I'm doing great and I can make and keep new synapses. So I think the bottom line is I think it's fine.
And the toxicities too, yeah.
Huge, huge. Yeah, those, as I said, I've always said, those are the toughest ones to get for the people who have massive exposure to mycotoxins. And we've been really fortunate, people like Dr. Neil Nathan, who's done. We have a training now out, Recode 2.0, for anyone interested in training in this. And we've got some fantastic people. Neil Nathan gives several hours of talks on this, and Dr. Anne Hathaway, Dr. Chris Shade with all the chemotoxins. So yeah, it really is a field unto itself to learn these things. And as you say, yes, these toxins, huge issue.
We got a question here. What is your stance regarding Pendergrass and Haley's 1995 hypothesis on ApoE4 isoforms having a decreased ability to bind metals, heavy metals, due to the lack of cysteine, the presence of arginine residues and the lack of cysteine residues?
Yeah, and again, as I mentioned earlier, there are multiple effects of these various isoforms. By the way, they have different affinities for their receptors. They have different impacts on DNA. They have the metal binding issue. So again, all of these monoetiological reasons, like this explains everything, have not panned out in this disease. So yeah, I think that's one of the many, many effects of this. It was also pointed out to us years ago, oh, it's all about A beta. Making reactive oxygen species. So we actually created transgenic mice with A beta with and without the ability to make these reactive oxygen species at a specific residue. And it turned out they both got Alzheimer's. Or in this case, Moutzheimer's. So again, I think it's one of many mechanisms. It has this striking effect, as I said, on gene expression. It has a striking effect on inflammation, on all of the above. This does really reprogram your cells. It's different programs, and you can take that into account when you treat these people.
Have you or any of your associates used emeramide as part of your protocol?
Yeah, there's been a lot of discussion on that recently, and a couple of people have been using that. And so we've tended to use other approaches, but that may turn out to be the best one. As I recall, it's not terribly easy to get right now. Is that fair to say?
Well, it's a research chemical, so you can't, it's not approved anywhere as a medication. So everybody's
the FDA is holding it up. The FDA, we're going to have somebody speak on it in December, but the FDA is holding it up.
Yeah, but that's the FDA is always last in terms of the world, approvals to get around to something, but it's not approved anywhere, and even in countries where it's more scientific and quantitative for approval process.
Yeah, that's a good point. So yeah, again, I think that there's going to be, taking the arsenal that we can all have access to today, there are going to be so many improvements. And I think emeramide is probably going to be one of them. There are many of these things coming out. And again, months ago when whole coffee fruit extract came out, I thought, great, here's an additional way that we can increase BDNF. And I think there will be other ways as well. So again, it's knowing the underlying drivers of the problem will allow all of us to be very specific about and very effective in the way that we deal with these things.
Have pancreatic enzymes been, between meals, been used to successfully reduce amyloid?
Yeah, great point. We certainly use these for people who, who need them for gut-related issues. I have not seen anyone try to use these as a way to reduce amyloid. And again, remember, we're not trying to reduce amyloid as the only, that's not the goal. The goal is to reduce the cause of the amyloid and then to start reducing the amyloid. There are several systems in the body that metabolize the amyloid. So there's one called neprilysin, which is it's a big one, which degrades the amyloid. And so people who have SNPs in their neprilysin actually are at much increased risk for Alzheimer's disease. Then there's another one called ECE, which helps to reduce amyloid. And then, of course, insulin degrading enzyme degrades both insulin and degrades amyloid. And that's one of the arguments that's been made is, yeah, as long as you have lots of insulin around, you're not going to degrade your amyloid well enough. So I don't know whether those sorts of enzymes would be helpful. I kind of doubt if they'll be as important as these other things that we know are the amyloid degrading enzymes. And my worry, I guess, would be that they may be degrading other things that you may not want them to degrade. So I think, again, we want to be as targeted as we can.
Do you have your favorite brain training options?
Yeah, I always talk about Brain HQ. Some people don't like it because it is a little stressful at times. But it has by far more published data than any of these others. And Mike Mersnick is a brilliant neuroscientist who's really the father of brain training and who designed all this stuff. And he and his current CEO, Henry Monkey, I think they do a great job. Now, other people like things. Elevate is another good one. It's a little more of a kind of a real world sort of thing. There are other things like Lumosity that some people like to use. Just be careful because some of these others don't have as much published data. People will always say, oh, we do brain games. Well, okay, where is your evidence that your brain games are actually helpful? With Brain HQ, there's a lot of evidence that they are helpful. So that's the only thing I would say. However, if you turn out, you really like some others, what we recommend then is, okay, do some of both. And just to make sure that you're not doing something that is not going to be particularly helpful.
What's the easiest and least expensive way to get tested for ApoE?
Yeah, great question. Probably. So we have something we just came out with called Precode that just is a very inexpensive way for people who are truly asymptomatic. And that includes ApoE and a bunch of other things. But you can do it even cheaper than that. That's like $250. But I think you can do it. I guess what's the latest on 23andMe? Is it $199 for that? So yeah, and that gives you a lot of other things as well. So that might be, I know if you do it as part of your doctor can order as part of other tests, and there are some places that can piggyback it on for like $20 or $30, but you're then doing other things as well. So just that alone, probably $199 is going to be the way to get it. And again, someone here may know better. If so, please speak up.
Have any of your protocols or your colleagues been using either hydrogen water or deuterium depleted water?
Yeah, this has come up a number of times. We haven't been using it. And I know some people love hydrogen water. I haven't seen enough data that convinced me that that's really an important part of this. But again, we're agnostic. As more data becomes available, absolutely, this may turn out to be a very helpful thing.
Okay, Susan, do you see some questions that I missed? Does anybody want to unmute yourself to ask?
Yeah, I did see some. One
Can I?
person,
Oh,
go
okay.
ahead.
No, Susan, go ahead, and then I can go.
No, you go ahead.
Are you sure? Oh, okay. Yeah, so I just want to get your feedback on a couple of things. That I've heard that hearing loss, they can possibly cause cognitive decline.
Yeah.
I don't know what your feedback is on that. There's a couple of things, but
Yeah,
one of them was regarding hearing loss and not using hearing aids.
Let me
My mom.
ask that first one before you go on to the second one, then we can go on to the second one.
Oh, okay.
You're absolutely right. And there's we're talking about this at last Friday's meeting because there is more and more evidence. You're absolutely right. Now, the issue before is this just that, yeah, you have poor support of your neurological systems. So you're going to begin to lose your hearing as well as your cognition. But more and more, as you said, there is an association. And in fact, fixing the hearing loss does seem to be helpful for cognition as well.
Wow.
So yes, the answer is it is something that's important to check on people and important to correct.
Well, let's say you have somebody, no names, like my mother. So she got hearing aids, and she keeps on losing them. She never wanted to wear them. So now she's not interested. She paid a couple $1,000s, but now she's not interested in getting them again.
Right.
So I guess we're kind of stuck.
And now you know why she's losing them. And so, yeah, it's up to you now to go and make sure that she doesn't lose them, and make sure that she, tell her, look, this is going to help your brain in the long run, not just your hearing.
About the brain also.
Yeah.
Yeah, and what about, I've heard, I don't know, coconut oil. Is that something that also, is that just a hype, or I heard that's supposed to be helpful
Yes
for the brain, coconut oil?
Yes and no. So here's the thing.
Oh, yes and no.
And again, so you've got to weigh the options here. So Mary Newport did a great job, and of course even wrote some books on this. There's no question this is part of getting people, this is an exogenous ketosis, and very effective for that reason. You're giving an alternative energy source to your brain. However, there's the negative side also. For many people, especially those who are ApoE4 positive, you're also increasing their LDL particle number. You can give them some inflammation as well, as Stephen Gundry has pointed out repeatedly, and you can end up with people who've now got more vascular disease. So there's a positive and a negative. So this is why what we've taken to, especially for the people who have any question about vascular disease or who are ApoE4 positive, I like to use this thing called KE1. Again, nobody pays me to use KE1. I use it because I think it's something that's helpful out there. It is a combination of ketone salts and ketone esters, and you can take it a couple times a day and help boost your ketone level. Some people do love MCT oil or coconut oil, but just be careful. Check your LDL particle number. As long as it's doing well, fine. There are other things you can do, obviously, slowly. What Julie G had suggested is you slowly switch over to more polyunsaturates and monounsaturates. That's another way to go. Yes, one way or another, you want to get those ketones up. If you like coconut oil and your LDL particle number is okay and you don't have vascular disease, hallelujah, go ahead and use some coconut oil. In the long run, try to get onto more of an endogenous ketosis.
Bern, do you have a question?
Yes, can you hear me?
We can.
Okay, I have a question for you, Dale. We
Yes.
spoke many times when I was back in UCLA. One of the questions I have you measured the glotho gene expression in Alzheimer's? Usually we find them underexpressed. That means they're high in phosphorus to calcium levels.
Yeah, it's a great point. And as you know, some nice work out of the Gladstone showing that the SNP associated with more, these people tend to do better overall, cognitive wise. So yes, it is clearly related to cognition. We haven't been measuring it. We've been doing things that should enhance it. But is there a clinical test now can you get this as a standard test from LabCorp or Quest or one of these groups to measure klotho levels?
UCSF is working on that, and they're doing predominantly a lot of research on diabetes, cancer, osteoporosis, and brain cognitive, but there's not an actual lab that you can request. But I think the future is going to be available with them, and hopefully we can have that available, because if we can see underexpression or overexpression means you give somebody vitamin D, calcium, K, you get a high expression. That means you have a less chance of getting these type of diseases.
Yeah, absolutely.
And then another question I had for you, I've been using methylene blue for nearly 20 somewhat years. And it's probably the most remarkable thing I've seen for cognitive function, especially in athletes. We've seen them improve in performance and cognitive performance. And I think it's related to also increasing complex 4, which is important in Alzheimer's and Parkinson's disease. I've seen it mostly with Parkinson's disease, where we have them walking again.
So this is so interesting. I'm so glad that you brought this up because I've been fascinated by methylene blue because there seems to be this interesting effect that you can bypass an inhibition of a specific complex, such as complex 1. So, theoretically, this is the great thing for Parkinson's. But here's my question for you. I've never been able to get this answered. I've searched the literature. I've asked various people, what is the redox potential of this? Does it sit between complex 1 and complex 4? Does it sit between 4 and oxygen? Where is this thing on the redox? On the redox status, or is this thing all over the place? I mean, something is not adding up here.
I agree. Mostly we see it more in the complex 4 with the cytochrome oxidase enzyme and its function mainly. That's where most of the data is coming out.
And what doses do you use?
That is something we're working with. We're using it between 0.4 milligrams to 1-2 milligrams per day.
So 0.4 to 2 milligrams per day. Okay.
Yes.
Not per kilogram, per day.
No, you can. There's been some studies where they have been using it 0.4 milligrams per kilograms, so you can go up. There's no toxicity. I've gone up to 25 milligrams myself.
Yeah, but as you know, if you go too high, it can be an uncoupling agent. So that's the big worry.
Right. You want to keep it in the
people who died from DNP years ago. People died from that. And so the worry is this could be another DNP if you give too much of it.
Yes, we found the studies on some of the studies going back to malaria and all that they were able to use high amounts with no toxicity. We're talking about 600 milligrams. This is incredible. Wow. Yes, I know. And I won't try that, but I think 1 to 2 is perfect.
And where do you, and which formulation do you use? Because it's not terribly easy to get this stuff.
No, we buy it from a chemical supply house. And then we exactly measure it correctly so that when we put it into a bottle, 2-ounce bottle, one dosage of the dropper tells you 0.4, 2 is 1, whatever, 8, 0.8, etc. We try to keep it in that 1 or 2 milligrams per range.
And when you're buying it, is this formulated for human consumption?
No.
Yes. Well, it's not
formulated. They formulated the people they buy it from. It would be for research use.
Yeah, that's the concern. How do you know that it doesn't have various impurities in it? Because I think they're selling it for chemical studies.
Yes, but most of the companies we talk to who are chemical supply houses, they do have a purity form, and we buy the highest purity.
I see. I got you. Yeah. What is it? Is it called Simply Blue? Is one of the ones? I think is tailor-made one of the. There's several ones that seem to be able to get this, but then I'm just each one has its own concerns about it. So I'm very interested in where you get it and how you use it. Yeah, I think that there's tremendous opportunity with this. Think about the other neurodegenerative diseases. We know the impact on complex 1 in Alzheimer's and impact on complex 4 in Alzheimer's, 1 with Parkinson's and 4 with Alzheimer's. But what about some of these others? If you look, for example, at PSP, there's a chemical that causes PSP, this adenosine that people drink in teas. Right. And many people get this because of that. And so they turn out this thing is an inhibitor of complex 1 as well. So theoretically, and this lowers their ATP, theoretically, methylene blue could be helpful for someone with PSP. Yeah. So I think there's real opportunities here. True Blue, here we go, yeah. Great,
there's many of them. Actually, when I was working with the athletes, we actually got it from the aquarium shop. We got aquarium methylene blue and seemed to work perfectly well. We monitored the athletes really closely when we used it. So we've never had any toxicity problems with them. And so I think methylene blue in general, you don't have to buy expensive, but we are getting ours now from a chemical supply house, which is high purity, consumption type.
Right. I'd be a little bit concerned about the heavy metal content, but if you take a pinch of tetrasodium EDTA and add it to it, it'll bind all the metals very nicely.
Okay.
Another thing, you know about niacinamide and NR and all that, Chromadex.
Right.
In combination with methylene blue and NR and niacinamide, we've also seen some very, very good results with Alzheimer's and Parkinson's. Especially with Parkinson's, we've had 2 patients who were in wheelchairs started walking again.
Wow, that's interesting. Wow. So have you written up these various studies somewhere and published them?
Not yet. I'm
Yeah.
retaining all the information from these patients of mine and working with their doctors on this.
Yeah, you got to get the word out. And I see there's some questions about does methylene blue or binding proteins, various things. I mean, I know people get upset about it because of what it does to their underwear, but are there other questions about other concerns about it?
Okay, well, we've got, I think it's maybe time to change to another question. We have a question here about, well, first of all, Carol says that the 23andMe Ancestry package, which is $99, includes the raw data browse for which you can look up the ApoE SNPs.
Awesome. Okay, great.
Okay, also we have somebody asking about foods to avoid.
Yeah, great point. And so, of course, again, each person's going to be different depending on their own food sensitivities. But yes, in general, we go into great length on this second book of all the foods to use, all the foods to avoid, all the workarounds, on and on and on. But in general, just the generic answer here is, so simple carbohydrates, you know, the biggest problem. It's a huge, of course, as we all know, it's a huge issue for our entire country. I don't know if anyone saw that The Food That Built America. If you've never seen that documentary, take a look at it sometime. Very interesting, all about Heinz ketchup and how it came to be, and you know, all the various things. And if you look at it, the bottom line for all these things, why they became so popular, is because they had more sugar than the previous things in their places. And so we all are, you know, got addicted to these things, and it's the food that built America is also the food that's destroying America. So it's amazing. So anyway, simple carbs, of course, grains, dairy, anything obviously with gluten in it. These are things that for many of us, and again, some people can get through these things. And then for people who still have autoimmune problems, I think Stephen Gundry's point about leptins, for those people who have autoimmune problems, looking at whether you're sensitive to those. Many people aren't sensitive to them, but for those who are, then that's important. But for people who have cognitive decline, the big problems are they're causing themselves leaky gut. They're causing themselves a pro-inflammatory lifestyle or a pro-inflammatory problem. And the biggest of all, that they have a high glycemic lifestyle. I have a whole chapter in the first book. If you want to give yourself Alzheimer's, I can show you how to give yourself Alzheimer's. And you may not have a diagnosis for 20 years, but your biochemistry will be Alzheimer biochemistry within a week. And you do everything wrong, you know, get high glycemic foods and lots of gluten and lots of inflammation and leaky guts and all this sort of stuff. You know, you're going to give yourself that chemistry that we associate with long-term Alzheimer's disease. So those are the big ones. Now, again, some people very sensitive to other things, but those are the big ones. And then be careful of saturated fats if you're ApoE4 positive, and if you have a high LDL particle number.
Do you have any data or any of your colleagues with ALS patients?
That is a great question. So we started this thing called the ARC project. So the way the Noah's Ark was 2 by 2 by 2, we wanted to just have a couple of people who were interested very early on in the stages of these various illnesses and who were interested in recognizing there isn't anything to do. And so we've begun to work with a few people who have macular degeneration and just begun on ALS. So my hope is we'll be able to see with ALS, again, looking at the theory, what is actually driving this. And by the way, there's a nice paper from Duke looking at people who made unexplained long-term survival from ALS and who seem to get better. And this guy does a very nice job of documenting, okay, these people happen to be doing these things. Maybe it had something to do, maybe it didn't, we don't know, but here's a list. And I think it's interesting, it's informative. But the bottom line is the problem there seems to be, again, just like there's a mismatch when you've got Parkinson's, it's about energetics and it's about complex 1. When you've got Alzheimer's, it's about this neuroplasticity network and all the things we just talked about. For ALS, it seems to be about the ability to clear glutamate so that these people actually have a hypermetabolic state at times. If you look at the various neurons in the nervous system, the central nervous system, the ones that have the greatest integration, the most neurons coming onto them for spewing glutamate onto them and requiring them to deal with it, which is an excitotoxin, as you know, the answer is motor neurons. And so it does seem to be a state where you're trying to keep up with this excitotoxicity. And there have been excitotoxic related studies in motor neurons for many, many years, and there are a lot of data around that. And some, I think, interesting work from Stephanie Seneff on this issue of glyphosate impacting your ability to clear glutamate. And so I do think, again, these people tend to have things that are the net effect is excitotoxicity. It can be because your clearance is poor. It can be because your exposure is too high. And of course, Paul Cox has done beautiful work showing that exposure to LBMAA, which is an excitotoxins, whether you get it through eating fruit bats or being around cyanobacteria, will increase your risk for LBMAA and will increase your risk for ALS. And he's got a program, they're now looking at high doses of L-serine as a way to compete and to reduce this. So again, I think as we understand the neurochemistry of these diseases, the arsenal becomes bigger, it becomes obvious. Okay, here are the things that we want to do. Each one has its own mismatch for that particular neural subsystem.
What's a good way for people to find Alzheimer's reversal physicians that you've trained?
Yeah, just to go on the website, you can go on drbredesen.com. You can also look at mycognoscopy.com because that is what tests to get. And there's a simpler one for prevention and a more complex one for reversal. And I should say we've trained now about 1,700 physicians from 10 different countries and all over the US. So again, for anyone interested in training, that's now available.
Is there a place that you can go to have the protocol provided to you as like a visitor, like a fasting center or a treatment center where you don't do anything on your own? It's all
that's a great point. So to go to a number of these people who have it set up, again, the ones I mentioned, Dr. Anne Hathaway, Dr. Kat Toops, Dr. Deborah Gordon, they're all doing this very effectively. Depending on where you are, we are in the midst of working with a group to set up clinics around the country that would provide this. So please hold tight. I'm hoping we'll have the first one up in the first quarter of next year.
Okay, JB Tho, are you ready with a question?
Oh yeah, sorry. Locating the MDs in Canada, and I guess the other thing was a question to you. Can we make this presentation available for, did you save a copy? Can we make a presentation available?
Oh, the
It's a
slides?
tremendous, about the slide deck at least, but it's been a tremendous presentation. Thank you, Dale.
Yeah, thanks. Yeah, and then I know last time I did this, Stephen, you put this thing up somewhere,
Yeah.
right? It was available.
It's on the Silicon Valley YouTube channel.
Yeah.
So this will be up in a week, maybe 2 weeks, maybe a few days. It's hard to know exactly when it's going to go up, but it won't be long.
And at locating MDs in Canada?
Yeah, there are a few I can mention offhand, but otherwise I would go to the website because it has all countries on there. But Randy Nipping is in Toronto, and Dr. It's Dr. Jan Venter who is in who's has a really nice center in Vancouver. But there are many others, and I don't know all of them offhand.
Okay, thank you.
Sure. Okay, we all set? Thank you, everybody.
Well, thank you all, and this will be posted on our website, www.svhi.com. Thanks all. We've got weekly Zoom meetings and hope to see you all again soon.
All right. Thanks again. Bye-bye.